work in quality and work with healthcare IT to how it helps in primary care. And I just haven't heard very much talk about primary care, and wondered if you could talk some about healthcare reform and what it's going to do for payment for this critical part of our healthcare system. I mean, I see that you were talking about discharging patients and the responsibility that the hospital has to make sure that the patient understands what they're to do. And I really see it as it's a partnership between the patient and the hospital and their primary care provider and primary care team. And I'm sure that you'll agree, and that those systems for how to do that are lacking or weak. And then the problem at the primary care site is that there isn't the money to do the work because of pay for volume, pay for visits. There isn't the money for the team that really, because that 15 minutes, like you talked about, isn't enough time to work with the patients with multiple chronic diseases. And it takes, and I just don't see that pay for performance is going to be enough money to pay for that team that needs to be taken care of. I know at Kaiser you have a way, you have a payment system that can do that, but most places don't. So can you talk about payment reform, healthcare reform, and this important need for funding care teams at primary care?
I thought I was asking hard questions, but she just asked, how do we fix Medicare's physician payment mechanism?
Yeah, I don't have the answer to that, but I actually have a suggestion with respect to reducing readmissions and the role that the medical office and primary care might play in that with the hospital. And this is going into a partnership with your hospital to risk stratify those patients that are being discharged, because one of the primary reasons for readmission is that patient has not been seen in the time frame that they needed by their primary care doc. And so just looking at the types of patients that are being discharged, establishing some criteria for risk stratification, and then having that hospital be able to make the appointments or alert you to make the appointments for those patients that need to be seen earlier may help you to reduce readmission. I don't have an answer, unfortunately, for how we can amend the payments for Medicare reform for primary care, unfortunately.
I don't have the answer either, and coming from a small state where a physician or a primary care provider can jump over to Connecticut or Massachusetts and get a 20 or a 25% pay increase. Our hospitals have been struggling in the state. The hospital that I came from before had their own primary care providers as part of the hospital entity, so we employed them because nobody wants to be a family provider or physician in that setting in the state of Rhode Island. In my current facility, we are starting to really look at how we provide care, come up with patient-centered medical homes. We have created a women's health strategy where we have a variety of services paid for by hospital-provided physicians all under one roof in the outpatient setting or the ambulatory setting, because we can't get physicians to do it because of the reimbursement challenges you raise. And that's not sustainable. And that's, the fear that I have about this is all going to fall apart, like we heard yesterday. So we don't have the answer, but I think organizations are trying to meet those primary care needs through organizational resources. And
it's a great question, and I think gets to the experimentation phase we're at with primary care physician practices. We do not have a sustainable model, but recognize it has to be more team-oriented and aligned and reflect the work that's been done.
And I would say that even within Kaiser, we can't do business as is. There's been significant changes to the reimbursement to the degree that our Medicare membership, we get much less reimbursement than we ever had, and the STAR program is not going to fill that gap. And so we've got to do primary care differently. So what does that look like? Is it the medical home model, where you huddle in the morning, for example, and look at your patient lists for the day and try to understand their needs and who needs to see that patient? Does it have to be the physician or a member of the care team? You know, the experimentation is going to be critical. And again, that's something where I haven't mentioned small tests of change, but where you can kind of tweak the system just temporarily for perhaps one patient and follow that patient for that visit or the next couple of visits and understand the impact of that patient, and then understand whether or not you have an opportunity to spread that to others, whether it might be effective. But the experimentation will be key, and I just don't think that anyone who thinks that they can continue to practice medicine in the way that they're currently practicing is going to be successful, regardless of whatever revisions are made to healthcare reform.
We have a question.